I'm going to be speaking tonight on diabetes technologies in type 1 diabetes with a little bit of a segue into type 2 diabetes. And I believe there's some opportunities for questions at the end, or you can use the Q&A panel. So these are my disclosures. So where was technology? Where have we come from in terms of advances in the management of diabetes? So you can see here on the left, this is one of the first productions of insulin by Lili, with a delightful needle on the left, which often had to be sharpened by the user prior to use. If we look on the right-hand side, this is one of the first insulin pumps. This was developed, I think, in the 1950s or 60s. This is a real insulin pump, and this photograph was taken at the Medtronic headquarters in the United States. You can see it's quite a streamlined device with lots of flexibility and really good if someone's trying to be discreet about the management of their diabetes. That's the first insulin pump, so how far we have come. So why do we need technology? Why do I think it's such an important thing to talk about? Well, that's because type 1 diabetes, despite good glycemic control, is associated with a double mortality risk to age-matched control. So this is a table from the Swedish National Diabetes Registry from the mid-2000s. And you can see here on the left-hand side, they've broken up the individuals with type 1 diabetes by HbA1c. You can see that the HbA1c, the individuals with an HbA1c less than 6.9%, so this is really good diabetes control. Despite this, they have a risk of death which is nearly 2.5 times that of their age-matched peers. And that risk goes up for cardiovascular disease, so it's nearly 3 times the risk of death for cardiovascular disease despite getting really good control. As you might expect, that risk goes up with worsening of control. So for people who have an HbA1c close to 10%, that risk is getting up to 10 times the risk. We also look at risk of adverse outcomes via proteinuria, or micro or small or large amounts of protein in the urine. You can see that with increasing renal involvement from diabetes, the increased risk of death from any cause and cardiovascular disease goes up. But does being on an insulin pump have any role in changing this risk and reducing this risk? Well, again, this is from the Swedish National Diabetes Study, and again, it's a pretty old study now from 2015, where they looked at nearly 20,000 adults with type 1 diabetes. 2,500 were treated with an insulin pump, and about 15,000 were treated with MDI, and that stands for multiple daily insulin injections, or the insulin pens like NovaRapid, Humalog, Lantus, Levemir. This is an old study, so the insulin pumps were older, some of the older models that we've had advances on to date. They followed them for about 7 years, and then they looked at risk of cardiovascular disease. So what I want to draw your attention to, these are survival curves, 1, 2, 3, and 4, and the adults who were treated with insulin pump are in the blue line. Those who were treated with injections or insulin pens are in the dotted red line. And what you can see is there's greater survival across the line for those treated with insulin pumps. So there was less fatal or non-fatal coronary heart disease, cardiovascular disease, and total mortality in those who were using a pump, despite pretty similar HbA1c. And we think that might have something to do with insulin pumps reducing hypoglycemia events in these users. So there's a clear advantage with technology here. So what are some of the currently available pumps that we have on the market? So two of the most common probably is the middle pump here, which is the T-Slim pump. On the right, we have one of the Medtronic insulin pumps, and there's a couple of different models available, most commonly the 640G or the 670G. And on the left-hand side, we have the Animas Vibe, which is quite an old pump now, less commonly seen, and the Ipso Slim pump on the bottom corner. And they all have different pros and cons, and people choose them for a variety of reasons. So what are the key components of an insulin pump? And apologies if people know this already, but I think it's important to go over. So each pump will have an insulin reservoir, which contains the small amount of insulin that is delivered by the pump, and that's generally changed every 2 or 3 days. There are operating buttons on the pump which the user can use to give an injection of insulin or a bolus of insulin. There is a battery unit which powers the pump, and that might be a disposable battery, or it might be a rechargeable lithium battery, as with the T-Slim pump. There's a screen, and that might display information like the amount of insulin that's currently being given, how much insulin is on board or active, or the glucose values if the wearer is using an insulin pump with a continuous glucose monitoring device. The insulin is administered by tubing, and that is connected to the wearer by an infusion set or a cannula, which is stuck in place with an adhesive. And that, as I said, that pump generally stays in place every 3 or every 2 days. So an insulin pump can be thought of as a really smart calculator, essentially. So before the diabetes educator or the endocrinologist puts someone on an insulin pump, we need to program that calculator with some important information for the 2 different types of insulin injections that it gets. So the insulin pump will have fast-acting insulin. That's the type of insulin that goes in the reservoir. And it gives basal insulin, which is this light grey colour. So this is the background insulin, which we can vary across the day. We can give slightly higher or lower amounts of insulin over a 24-hour period. And the basal insulin can be thought of like the Lantus or the Levemir that we're classically used to giving in type 1 diabetes. And we might choose to give slightly more insulin over the day, a slightly lower amount of insulin per hour over the night when the wearer is sleeping. The other type of injection that the pump will give is called a bolus. And you can see these are marked as these sort of big wave type insulins. And a bolus is something which is given at mealtime, so a higher dose of fast-acting insulin to account for glucose from carbohydrate. But there might also be a bolus if the wearer is hyperglycemic and they want to give a shot of insulin to bring the glucose levels down. So in order for the pump to work out how much insulin to give for that bolus, we need to put in a few variables. One of those is the insulin to carbohydrate ratio. So we'll format the pump and say that the pump will give, for example, 1 unit of insulin per 10 grams of carbohydrate or 12 grams of carbohydrate. It will vary from person to person. We'll also put in the insulin sensitivity factor or correction factor. And this is how much 1 unit of insulin will lower the blood glucose by. This might be 2, 3, 4, completely variable again. And we also need to enter the blood glucose target that the pump is aiming to correct to. And this might vary by time of day and will vary between individuals. So what are some of the pros and cons of currently available pumping technology? The advantages on the left, but there are clear advantages in HbA1c. So there's a number of studies looking at pumps alone, which have shown that pumps compared to insulin injections generally have a reduction in HbA1c by between 0.3 or 0.7%. And generally, the higher someone starts with an HbA1c, the better impact they get with starting on an insulin pump. We know that insulin pumps are associated with a reduction in severe hypoglycemia, and by that I mean a low sugar level where someone else is required to treat the hypo. As I've already alluded to, we can vary the amount of insulin that is being secreted by the pump over the day, and we can also vary that according to exercise. So if the wearer is about to go to the gym or go to a walk, they can tell the pump that, and it will give slightly less insulin before and during that period of exercise to avoid hypoglycemia. There's nothing so frustrating to someone with type 1 diabetes as having to eat to counter from hypos from exercise, and the pump can really help with that flexibility. We can also give slightly higher doses of insulin, for example, to account for the dawn phenomenon. So dawn phenomenon is something where the hormone cortisol level will rise overnight around 3 or 4 a.m. and generally push sugar levels up. So if someone has an injection of Lantus at bedtime, that insulin is flat overnight. But with an insulin pump, we can give slightly higher insulin doses to account for the cortisol-mediated rise in sugars. We know that insulin pumps are associated with an improvement in quality of life, both for the wearer, but also, for example, with young children with type 1 diabetes, there's an improvement in quality of life for the parent who's worrying about their child. And we also think that insulin pumps might minimize glucose fluctuations or how much the sugar levels are going up and down across the day. What are the disadvantages? Well, we might hear a little bit more about these later, but there are clearly some expense with insulin pumps. So the pumps cost on average around $10,000. They do need to have with private health insurance, and the consumables with the pump are an added expense. As I've mentioned, the insulin in the pump is a fast-acting insulin. So if there's any issue with the pump, the tubing or the cannula that is connecting the pump to the wearer, if that kinks, then insulin is not administered and the wearer can go into ketosis or diabetic ketoacidosis really, really quickly. It is a wearable device, and this might be a problem for some people. It's a visible reminder of having type 1 diabetes, but also I have a lot of patients, who do contact sports like martial arts or grappling, and then the pump might be in danger of being pulled off during the sporting event, so that's an issue. Or swimming, for example, long distance swimming, that might be a problem as well. And the pump does require a lot of education, so that the wearer needs to talk to the pump, they need to count their carbohydrate, they need to interact. So there's a high degree of education and knowledge that's needed to get the best out of the pump. But is an insulin pump enough? Well, I would argue no, a pump is not enough. And what we need to be thinking about is continuous glucose monitoring. So continuous glucose monitoring are devices which continually measure blood glucose levels across the day. And this is some data from the Type 1 Diabetes Exchange Registry, which is a big database of children and adults with type 1 diabetes in the USA. And you can see they've grouped them by age. So here we've got people under 13, here they're 13 to 26, and here adults greater than 26. And they group them by modality. So the black bar are people treated with pens, insulin injections alone. Their HbA1c on average is the highest. The next bar down, this horizontal line, are people with type 1 diabetes treated with a pump alone. So there's a slight improvement in HbA1c. But even better, in the white bar, these are people treated with injections and a glucose sensor. So they're doing even better than the insulin pumpers. And the best group overall, this diagonal line, and these were people using a pump that's talking to a continuous glucose monitor or sensor. So it seems like the combination of the two technologies is really what's needed to get the best result in HbA1c lowering. That's been shown in a number of studies. So the Diamond study, where adults were randomized to sensors or finger pricking, and the sensors lowered HbA1c. They minimized variability or coefficient of variation, so how much the sugars are fluctuating across the day. They reduced the number of hypos, and they also improved something called the time in range, which I'll talk about in a few slides. It was the amount of time spent between 3.9 and 10 in terms of a sugar level. I'm not going to focus too much on type 2 diabetes, but we know that sensors also have a benefit for type 2 diabetes. This is a study of continuous glucose monitoring in type 2, people on insulin. So the people in the dark line are those who are monitoring their sugar levels with finger pricks. And in the dotted line there, the individuals who are allocated to a sensor, and there's a significant improvement in HbA1c over this 52-week study. So these are some of the currently available sensors. So this top device here, this is the Dexcom continuous glucose monitoring device, and it's connected via Bluetooth technology to the phone here. It can talk to a smartwatch as well. On the bottom part of the screen, this is one of the Medtronic continuous glucose monitoring devices. This one is talking to a mobile phone. There is another type of Medtronic device that will talk to an insulin pump. So these top and bottom, these are continuous glucose monitoring devices that are measuring blood glucose levels or interstitial glucose levels continuously across the day. This middle device, this is a flash glucose monitoring device, the Freestyle Libre device, and I'll talk about the differences between the two options. So here we have a diagram of what is a continuous glucose monitor, what's it doing, how does it work? So with a continuous glucose monitor or sensor, there's a transmitter which sits on top of the skin, and this is connected to a glucose sensor which is thrown away at the end of the sensor period. There's a little electrode which sits through the skin, and that sits in the interstitial fluid around the cells. And the sensor every 5 minutes is measuring the glucose in this interstitial fluid. Now, it's really key to remember that the sensor is measuring interstitial glucose, not blood vessel glucose, because it takes about 20 minutes for the glucose in the blood vessel to move into the interstitial fluid. And so there's a 20-minute time difference. If the wearer is doing a finger prick and measuring blood glucose level, there may be then a lag between that and the glucose value that's measured in the sensor. And that can be a little bit frustrating if glucose levels are really rapidly changing, for example, after exercise or after eating, that the glucose on the sensor value will lag slightly behind the finger prick value. This is the flash glucose monitor, the Freestyle Libre device. Now, the difference with this is the glucose value isn't continually measured and shown to the wearer, whereas the continuous glucose monitoring devices will give alerts and alarms if blood glucose levels are going up or down. The Freestyle Libre device will only show what the glucose value is if the device is flashed. So this Freestyle Libre glucometer is swiped against the sensor, and every time that's swiped or flashed, it will show a blood glucose. So here the glucose is 5.3 millimole, and it will also give a trend arrow. So you can see here the arrow is straight across, so it's showing that the glucose is nice and stable, and the person isn't likely to have a hypo or hyperglycemic event. So every time they flash the device, this is showing the glucose, but it isn't giving alarms of sugars going up or down. Now, that might be a problem for someone with type 1 or type 2 diabetes who is having a lot of worried they might be having low sugar levels overnight. This device might not be the best option because it isn't going to alert with a low and wake them up to treat it, whereas the other devices will. But this device is the cheapest on the market. And if the wearer swipes or flashes the sensor every 8 hours, it will store or record the preceding 8 hours of sensor data. So for example, if someone flashes this device right before they go to bed and then flash it first thing in the morning, we'll be able to see what the glucose patterns have been overnight. And there are some ways to get around those alerts and alarms. There's some other ways which are not been approved, that people do add things onto this sensor to get alerts and alarms, but as it stands, it doesn't give alerts. Okay, so this is a table, it's outdated now. There is another Dexcom sensor, but it's showing some of the Medtronic and some of the Dexcom sensors. They have a variety of time lapse. Generally, they last for about 7 days, although some of the devices can be extended to extend the life. They all have slightly different adhesives and slightly different compatibility, and they all use different transmitters. So if the wearer is using the sensors continuously without subsidy, then they will vary in terms of price between about $2,500 to nearly $4,000 per year. So it's prohibitively expensive for most people, and that's why the subsidy is so important. The cheapest, as I've mentioned, on the market is the Freestyle Libre device, which is just over $90 a fortnight. And so often if someone can't afford to use the sensors continuously, it might be something that they use every now and then. Maybe if the HbA1c has gone off, or it might be before they come to see you for an appointment, so you can tweak their insulin doses, and that can be really, really useful. So this is some of the data that we might get from someone who is using a continuous glucose monitoring device. So this is these are two different patients from the Royal North Shore Clinic. They're both using Dexcom, continuous glucose monitoring. And so you can see here two different traces, and clearly when you look at it, these people have the same HbA1c. They're both hovering around 8%, but they have really different glucose traces. So here you can see the orange line. I'm just going to get my pointer working. This is the average or median glucose. The blue bar, the thickness of this bar, is the interquartile range, so the 75th centile or 25th centile, that's sort of the variance in glucose levels over the day, and there's real outliers in this dotted green line. So it's giving us an average and how much the glucose is varying. So we can at a glance see that this person on the right has a really pretty stable profile. It's not going up too much with food, whereas this person on the left is having a big spike in blood glucose levels, looks like after lunch, so after 12 p.m, as well as late in the evening, and it's staying high overnight and then coming down around 6 a.m. This is really important because it's going to clearly impact what advice we give to both of these individuals, and maybe change what advice we give them for their insulin doses. And one of the things we can get out of this trace is called the coefficient of variation, or the variability measure. So the coefficient of variation here is 33%. Here it's 46%. So this is a stable profile with not many fluctuations over the day, whereas this person is having lots of variability and it's an unstable profile. This is a sort of glucose profile we might get from someone wearing a Freestyle Libre device, that flash glucose monitoring device. And again, it's very similar. We get the average glucose, we get the variability or the range in glucose levels across the day. Here we'll get a likelihood of having a low glucose, and also a variability measure here. So it's sort of a traffic light guide, red, amber, or green in terms of low variability to high variability or fluctuations over the day. So in order to make treatment decisions or adjustments in medication based on the data we're getting from a continuous glucose monitoring device, we need to be getting people to wear them for at least 2 weeks, because shorter than that time, it's not really enough information to make a good recommendations. As I've mentioned, we need to not just be looking at the trend, but also looking at variability and how much the sugars are fluctuating over the day with a coefficient of variation. And as I've mentioned, just like there's an HbA1c target, there's a coefficient of variation target. So we should all be trying to aim for a profile which is less than 36%. We can also look at the time in target range, the percentage of the time that the individual is sitting between a glucose of 3.9 to 10 millimole. And there are now recommended targets for what we should be advising our patients, the amount of time to be spent between 3.9 and 10. And the continuous glucose monitoring devices, or the flash glucose monitoring device, will also give us an estimated HbA1c, or a glucose management indicator. And I have to say that's really fantastically useful in the realm of telehealth, where maybe people are scared to go and have blood tests and want to get an idea of what the average control is. We can actually get an estimate on the continuous glucose monitoring device. So again, this is a Libre view. So here we can see the average glucose, the variation in the glucose. We have this graph in the top right hand side, we've got green is the target range between 3.9 and 10 millimole. And this is giving us the time and target range. So here 70%, so this person is meeting the recommended time in the target range. We can see the amount of time that they're spending below 3.9 and below 3, and the time above 10. Here we can see the average glucose, which is 7.8, their estimated HbA1c or glucose management indicator, which is 6.7. And here's that glucose variability measure I mentioned, and there's a 37.2. So it's nearly at target, and the target was 36% or under. This is an individual, again, a real life individual using a Dexcom, continuous glucose monitoring device. So they haven't given us an estimated HbA1c here, and I suspect it's because we don't have enough data to review. It'll give us the average glucose. It will give us the time and target range. So here this person is spending 64% of the time in the target of 3.9 to 10. And what I think is really useful about the Dexcom continuous glucose monitoring trace is it gives the best day. So it can be quite disheartening when someone's spending a lot of money, a lot of time trying to get their glucose improved, and they're using the continuous glucose monitoring device. If we just look at it and it doesn't look great. Whereas the Dexcom will give the best day, and we can see this was nice and tight. There weren't many fluctuations after meals. And then we can say, well, let's try and replicate what happened on that day. That was a really good day. Let's try and change that and make that happen every day. Again, here's the same, I think different wearer, with a Dexcom continuous glucose monitoring device. So their estimated HbA1c is 67%. They're spending nearly 70% of the time in target range. Their variability score was 40.7%, so not perfect. And again, you can see that there's tweaks, and we'll also get a breakup day by day. So this is the average, but here we can get a breakup of the day by day if we want to look at each individual day to see what happened on that occasion. Okay, so I mentioned that there are targets for the time in target range, and these targets, just like there are varying HbA1c targets according to various age groups or according to complications and stage in life, there are different targets for time in target range. And we can only look at time in target range when people are using technology of continuous glucose monitoring. So on the left-hand side is a column for an individual general overall, an individual with type 1 and type 2 diabetes. So in general, these people should be aiming for a time in target range of 3.9 to 10, greater than 70% of the time. And again, less than 25% of the time spending above 10, and less than 4% of the time under 3.9. If someone is a bit older, just like we might aim for a slightly higher HbA1c, or if they don't have any early warning signs of hypos, or they might have lots of complications, then we might accept a slightly less stringent target. So we might only be aiming for over 50% of the time in target range and accept a slightly higher time above 10. And that's probably because we think that hypos are bad for this group of people. Now, the other big group of people that we treat are those with type 1 and type 2 diabetes as well, in pregnancy, aiming to fall pregnant or during pregnancy. And they obviously want to keep the blood glucose level as close to the normal range as we possibly can. So the actual target values change. So in type 1 diabetes in pregnancy, we're aiming for 3.5 to 7.8, and we're aiming for 70% of time or more in that target range. So as I said, all of this information is only possible when someone is actually using the technology or continuous glucose monitoring. So I've given these things a good rap, but are there any pitfalls? And I would have to say, yes, there definitely are. All of the continuous glucose monitoring devices do have possible interference. So particularly this graph is the Dexcom sensor, one of the older sensors, and this is a Medtronic sensor. And they both have some interference with, for example, paracetamol. A high dose vitamin C can also cause some interference with the sensor accuracy. So that's something to be aware of. The majority of these devices, both the Dexcom and the Medtronic continuous glucose monitoring devices, require calibration. And calibration is where the wearer needs to do some finger pricking to get a capillary blood glucose level a couple of times across the day to check that the sensor is accurate. So the sensor will look at that capillary blood glucose level and check that the sensor glucose is pretty close to the finger prick, and it's just a safety measure. The Freestyle Libre doesn't have to have the finger prick calibration, and one of the new Dexcom continuous glucose monitoring devices I'm about to show also doesn't need the calibration. There are issues with accuracy, particularly in the first and last days that the sensors are put on. They're probably not as accurate. And depending, basically, I think you get what you pay for. So I tend to think that the more expensive sensors tend to be a bit more accurate. And that is an issue for some people, particularly when they're aiming to make treatment decisions based on the glucose value that the sensor is displaying. Sometimes these sensors don't work as advertised. They may not last for the full amount of time, the 7 or 10 or 14 days. But I have to say the companies are generally pretty good. So I always encourage people wearing the sensors, if they fall off or they stop working, to call up the company and they should send a replacement. I mentioned that the pumps and the sensors are stuck to the person with adhesive tape, and this can often be a big problem. It can cause contact dermatitis and irritation, and that actually may be something that puts people off going on this technology. There are things we can do. There are wipes and tricks and ways to get around this. And all this sort of sticky adhesives but for each device are different. So what I tend to do is, if one doesn't work, rotate through the other sensors until one works for the wearer. So this is the new Dexcom G6 sensor, which I mentioned has just been released. This is quite expensive. It's about just under $4,000 a year for continuous use, but it doesn't need any finger calibration. So once it's on, it's good to go, and the wearer can make decisions based on this sensor. Lasts for 10 days, and it's quite an exciting sensor. I think a lot of people will try and change onto this when they can, but it isn't currently subsidised. It's not on the NDSS sensor subsidy. So that brings me to the subsidies. So the National Diabetes Scheme does subsidise continuous glucose monitoring. That's why there was that poll question earlier. So the current guidelines, when are people eligible, is when they are under 21 with type 1 diabetes. If they are under 21 with conditions similar to type 1 diabetes and needing insulin, and this is generally, so if they've had pancreatic surgery or cystic fibrosis, or they have genetic rare forms of diabetes and need insulin, then they are also eligible. An individual 21 years of age and older with concession status are eligible for sensors, and that might be people with Aboriginal or Torres Strait Islander, people with a DVA card, a pensioner card. So they don't need to display, we don't have to meet any clinical type criteria. They don't have to have severe hypoglycemia or absent hypo symptoms. They just need to have a concession status, and that's all we need. And the other thing which is newer is pregnancy. So individuals with type 1 diabetes who are actively planning a pregnancy, during a pregnancy or postpartum, are eligible for all of the continuous glucose monitoring devices. Unfortunately, not people with type 2 diabetes, so they do miss out at this pregnancy cutoff. So I think it's really important. I put the website down there, but if you do have a patient who is eligible, even if they're a bit iffy, I encourage you to fill out the subsidy and get them to try their sensors. And often the companies are very good about giving a free device for the wearer to try before they commit to one particular model. So what happens if we combine the continuous glucose monitoring or sensors and insulin pumps? Does that make any difference? And this is something called sensor augmented pumps. Well, the answer, as you're probably thinking, is yes, it is a benefit. So sensor augmented pumps, there's two types. The Medtronic and the Thyssen will be able to do this. So here on the right-hand side, you can see there's a sensor glucose on the y-axis and the time of day on the x. And the yellow bar, this is insulin. So the pump has talked to the sensor and anticipates that the glucose level is likely to drop to the low level in blue. It's likely to have a hypo. So the pump will suspend the background insulin and only restart that once the glucose level gets to the safe range. So this type of pump has been shown to significantly reduce the amount of time in low or hypoglycemia. And I think what the key thing is, it's not causing a deterioration in HbA1c. So there's less hypos, but there isn't rebound highs. So it's a really good clinical advantage. It doesn't always work. So if someone is given a big bolus for eating a meal or a correction, the pump can't take away insulin that's already been given, but the majority of the time it does avert hypoglycemia. This is a bar graph showing the benefit of the predictive low glucose suspend, the pump talking to the sensor. And you can see here, this is median and mean time spent below 3. There's a significantly reduced amount of time below 3 with the predictive low glucose suspend feature of the pump. So the next advance in technology are the hybrid closed loop insulin pumps. And this is currently available. This is the Medtronic 670G pump with the Medtronic sensor. This was released in Australia over 12 months ago, and it's a really exciting advancement in the management of diabetes of type 1. So this is designed that the pump, we can see here, it's on the abdomen, and there's a sensor there that's connected to a transmitter on the abdomen, and the sensor is talking to the pump. And the pump is adjusting the amount of background or basal insulin that it's secreting to keep the glucose within a target range. And the Medtronic 670G allows us to pick 2 glucoses, so 6.7 millimole, and we can sometimes aim for a slightly higher 8.3, for example, if someone is doing exercise. Now, it's closed loop means that the system is closed. It doesn't need any interaction from the wearer. So this isn't entirely closed. It's a hybrid closed loop pump, or a hybrid smart pump, because it will adjust the background insulin, but the wearer still needs to tell the pump when he or she is about to eat, tell the pump if their sugar levels are high and they need to do a correction, and they still need to be doing some calibrations or finger pricks around 4 times a day to check that the sensor is working well. It is a really exciting advance. So there's been studies in both adults and children where, when using this pump in the smart or automated mode, it significantly increased the amount of time in the target range of 4 to 10, and significantly reduced the amount of time with hypos, and significantly reduced HbA1c. And you can see that on the bar on the right. So sensor glucose here, insulin on the bottom. The red is the smart pump and the grey is a traditional pump. So you can see that glucose is lower, particularly overnight. There is some still variability with food. And what I find most interesting is this is how much the insulin is varying across the day, as opposed to the grey bar, which is what the doctor or the nurse is programmed into the pump, which is pretty static. But this smart pump is adjusting the insulin continuously. Is it as good in real life as it is in the trials? Well, yes, it is. On the right-hand side, this is real-world use of the 670G. You can see that people, this is time in 70 to 180 milligram per deciliter, or 3.9 to 10. So they started off with 66% of the time in 3.9 to 10, and in the auto mode, they went up to 73% of the time. And remember, the target is greater than 70% of the time in 3.9 to 10, so it definitely works. This is an example of someone newly commenced on the Medtronic 670G pump. So this is the kind of upload that we would look at either by telehealth or in face-to-face consultations. So the blue line is the most recent 2 weeks. The orange line are the 2 weeks prior. It will give us down below the time in auto mode. So most recently, they've been using the pump in the smart mode for 96% of the time. We're getting this glucose management indicator, which is the estimated HbA1c, and that's in about the 6%. We get the variability measure, and you can see that that's improving. So it's now 31%, so it's quite a stable profile. See the number of calibrations a day, and we can also see the breakup of the insulin. So how much is basal, or the background insulin, and how much is bolus, for example, giving corrections or insulin with food. We then here would get the number of times that the pump would exit the smart mode, and here we get the time and target range. So this is not perfect. We can definitely improve on this. So the time and target range here is only 50% of the time. So what's coming? So future hybrid closed loop options are the tandem T-Slim pump talking to the Dexcom G6 CGM. So this pump is currently available, and we have plenty of people who are using this pump, but it's not currently a smart pump. It doesn't have the capacity to adjust the insulin to keep the glucose within a target range. But this particular type of pump is sort of like an iPhone, that it has the capacity to be pushed a software upgrade, just like we can upgrade our phones, to then be able to work as a smart pump. And this has been trialed in the US, and it looks very, very exciting. Here, this is the trial data from the Tandem T-Slim hybrid closed loop pump. And you can see there's a significant reduction in HbA1c, around 30.33%. There's a significant amount of time spent in the target range, so 11% more time in target range, so 71% as opposed to 59%, and less time spent in lows. And here down below, so you can see the percentage of time in target range. So the red is the smart pump, particularly overnight, spending much more time in that 3.9 to 10. Now, I would say the disadvantages with these pumps, as I've mentioned, the target being in the 6s. This is unfortunately not tight enough for everybody, and in particular, it's not tight enough for pregnancy. So particularly in type 1 diabetes, we want pregnancy, we want really good control. These pumps are unfortunately not quite there in terms of being used in pregnancy. So in conclusion, continuous glucose monitoring or flash glucose monitoring has clinical benefit for type 1 and type 2 diabetes, although I haven't really mentioned type 2 much tonight. We get information that's really useful in our clinical consultation. So variability, we get time and target range, and there are new targets for this. When we're combining the sensors with the pumps, that's an even bigger advantage with type 1 diabetes. And the hybrid closed-loop pumps or smart pumps, the Medtronic 670G, is happening now, and the T-Slim with the Dexcom G6 CGM should hopefully be in Australia in the next little while, so it's a watch this space. So Jenny is kindly agreed to participate tonight. She happens to be someone who lives with type 1 diabetes, and she's, I think, agreed to participate and answer some questions. So Jenny, do you mind if I ask, how do you treat your diabetes? I don't know, how are you managing your diabetes currently? What do you use, any technologies, and if so, what do you use?
Okay, so I've been type 1 diabetic for 25 years, and previous to that I was always on injections and finger pricking. And then in January 2016 I found out that I was suffering with a kidney issue with proteinuria, and I wanted a bit more better control. My BSLs were always pretty good. They're about high 7s to mid 7s. And I decided that I was going to try CGM. So I went on and tried the Libre Freestyle for a couple of years. I was getting really good control with that, with the flash CGM, but I was getting really nasty skin reactions. So after about 2 or 3 years, I decided I couldn't cope with the reactions, and I still wanted to use the CGM. So I decided to investigate, and I changed over to the Dexcom G5 CGM, and that was really good. But then I also wanted to improve the BSL even further, so I decided to change to a pump. As long as I could have a pump that worked with the CGM together, I was more than happy. So in January 2019, I changed from the injections and finger pricking to the G5, Dexcom G5 CGM, and the pump, the T-Slim pump, working together. So it's probably been about a year and a half, and the improvement in my BCL has gone from 7.5 to about, or 7.3 to about 6.5. So I've had really good results, and my endocrinologist is very happy, and it's a big improvement. It's a bit different to using the injections and the pricking, but I wouldn't go back. I love it, yeah.
And how did you find there was much sort of, was there more involvement? Did you find you had to really upskill with education when you shifted from the pens to the pump and the CGM? Did you find, was that challenging?
In some ways it was, in some ways it wasn't, because I'd always been very involved in, counting carbohydrates and counting your sugars, and I was always very aware of what my levels were, most of the day. But there was a little bit of technology learning about how a pump actually works. I went to an information session with AMSL out at Chatswood, about actually to 2 information sessions. I worked with an educator there, and then I also worked with my diabetic educator, George Barker, here at Hornsby Hospital. So I probably had about 4 to 5 sessions with people learning how a pump actually physically works, to get my head around all the basals and the bolus, because at that point with the needles you were going from your Levemira twice a day for your long-term, long-acting, and then your Actrapid or Nova Rapid for your fast-acting, whereas switching from having the 2 different types of insulin to going to the one type, which was the basal and the bolus, it was a little bit of learning, but it hasn't been hard, no, to be honest. It hasn't been hard, no.
And have there been any downsides to using the technology? Have there been anything you wish was different?
There's 2 things. One is the expense. It's incredibly expensive. Like you were saying, I don't qualify for the under 21s. I don't qualify for the pregnancy. I don't qualify a lot of things. I'm 55, so I don't qualify for anything. But the reason I work is to pay for this, because I can see the benefits in long term in my own health in having a better control. And the other thing is, if they can work out a way of me not producing quite so much rubbish, because as you said, you have to change the infusion site and the cartridge and everything every 2 to 3 days. So the amount of plastic and waste that you produce by using the pump is actually quite substantial. If they could work out a way that, because the vial of insulin, as you know, comes in 300 units, and that's in a glass vial, if they could work out a way of transferring the capability of the plastic tubing to be able to cope and maintain the feasibility of the insulin for more than 2 or 3 days, that would exclude that problem. But that's the only sort of downside that I can see, is the amount of waste that I produce now. Whereas before, 1 pen was all I would really make. So, yeah.
And do you adjust the basal rate on your pump? So do you use temporary basals, for example, when you're exercising or you're having a busy day to stop hypos?
Yeah.
Or so
Yeah,
tell
I
me a
do,
bit about
yeah.
that.
So I exercise probably 4 days a week, at first thing in the morning. So I just make sure I'd always do look at the, you check the levels anyway, but I also do a calibration twice a day, as you said, once in the morning, once in the afternoon. So I always do a calibration just before, and I'm a bit low, then I'll adjust the basal or the bolus. I'll adjust a little bit, or I'll eat something, the same as I would have done before. But also, the other thing is that when I do exercise, I actually turn the pump off altogether, because I go for a run or for a class. And it's incredibly difficult to do that sort of high intensity exercise with a pump attached to you. So I turn it off, but I still, when I come back, I reconnect it and everything else. But you do have to adjust. You still have to know how insulin works with the carbohydrates. So that's what other thing I was going to say was, people that go straight from, that are young diabetics, are just diagnosed, and they go straight from being diagnosed straight to a pump, and they just have, the pump is like a little computer that works it all out for them. They just put in what they can eat. They seem to, that they need to understand how a carbohydrate unit works with the insulin and how it actually functions. If they don't learn that, I think they're going to be quite disadvantaged in understanding how the system, how the body operates, if that makes sense. But yeah, it's just one little thing they've got to be aware of. But
And have you ever had a nasty scare, was it of a hypo or anything with the sensors alerted you or alerted a family member? Has that ever happened to you?
yeah, I have. I was having a lot of lows of a night time, and having the sensor, not so much the flash, like you said, it doesn't alarm you, but with the continuous, with the G5, the alarm would go off in the middle of the night, and that would actually wake you up. Whereas I think if I didn't have those, you would not have been aware. So yeah, the alarm does go off, whether it goes high or it goes low. I think the alarms are very, very important, because they do make you aware of where you are and what's happening. Yeah.
And I've talked about that we think the T-Slim pump might become a smart pump. Are you looking forward to that? Is something that you wanted to do when it becomes available?
Yeah, I'll certainly have a look at it when it comes available. I mean, like I said, I'm very, very happy with what I have now, because like I said, it's not the closed loop, but it's as close to replacing my pancreas as I can get. The sensors work with the pump and it all talks to each other. And that's what I wanted to do. I didn't want to have the 2 insulin injections and the fingerprinting as 2 separate things. I'm very happy to put them all together. But if they could make that technology even better, I'd be willing to have a look at it, absolutely. Yeah.
Well, hopefully it'll come. I think it will.
I hope so. I hope so.
All right, do you have any other, Jenny, is there anything else you wanted to mention?
I just think it's a huge improvement. It took me quite a few years to come to the conclusion. My endo tried to convince me quite a long time ago to change, and I was very stubborn. I said, no, I was quite happy with what I did. I'm not saying that I regret not changing earlier, but I'm really pleased that she persevered and convinced me to change to a pump, because it's made a huge difference. Yeah, I mean, like I said, the BSL comes down, everything else, and your long-term health is very important. If I can stave off the long-term complications earlier than they would likely come with just injections and less control, then it's a good thing, absolutely.
Yeah, and look, we think pumps are generally associated with, there's some evidence there are less complications with pumps. So, so I think definitely it's the way to go.
I think so.
Yeah.
Yeah, it is. Thank you.
Perfect. Thank you.
So my talk is, so I don't have any conflicts of interest, and I'm very excited to talk about diabetes therapy. So Emma's given us a great run through of type 1 diabetes and all the new technologies associated with it. Mine is more really more sort of general bread and butter, more in type 2 diabetes setting. So we all know that the HbA1c is generally a marker of diabetes control. And this is just an interesting slide to show basically what your average glucose level is if you had an HbA1c. So as a guide for your patients sort of glucose control. So I know that we all generally aim for a 7% target. So that's actually giving yourself a guide that your patient's average glucose level is 8.6. Obviously, there's much variations, and it's interesting when you do use the flash monitoring or the continuous glucose monitoring to see just how much that variation can vary from person to person. And in terms of what that means, as in terms of having HbA1c as a target, I guess this is not a new slide to anyone, but using the HbA1c needs to be an individualized target, and the approach to management of diabetes is really an individual approach. So we know that there are a lot of features about a patient's disease that's usually not modifiable, such as their risk of hypoglycemia and drug events, disease duration, life expectancy, or their comorbidities, and their established complications. And the presence of that combination of things will give you a guide as to how tightly you want to aim for the HbA1c. Obviously, there's all the things that we do as clinicians try to modify, which is the attitude and the expected treatment effort, and also the resources and the support systems we have around us. And these things we can help them with, whether it's more referral onto other health professionals or, using a more holistic approach to their care and trying to drive their motivation. And I guess I just wanted to hammer home the legacy effect. So this is something that we were taught as early endocrinologists, as the legacy effect is quite important. And I think this recent study, which was published last year, really shows just how important this is. And I think we don't really take that on board, just how important it is to have good control early on. So this is a difficult slide to explain, I guess, but what I wanted to show you is that when you compared HbA1c of 6.5%, so that's this line here, patients who had higher HbA1c, so 6.5 to 7, 7 to 8%, 8% to 9%, and 9% or more, they actually had higher odds ratios of all these events. So microvascular events in panel A, macrovascular events in panel B, and mortality. And this was across the board. So, and we're talking about patients who were even followed up at year 1 of diagnosis up to year 7. So even patients who were early in their diagnosis of diabetes, if they had a better HbA1c aiming towards 6.5%, this really meant that they had less chance of having up to 10 years of follow-up, these three endpoints. So it's really, I think it's what it tries to say is basically in patients with newly diagnosed diabetes and up to 10 years of, and those who survived more than 10 years, those who had higher HbA1cs were associated of greater than 6.5% for the first year after diagnosis was associated with worse outcomes. And so it's really, really, I think it imparts on us the importance of intensive, immediate treatment for newly diagnosed patients. So I know sometimes we might know that they have diabetes and we give them a few months or maybe even years to really get the HbA1c under control. And this is really, this study is really going against that approach, and we really do need to get them on board and getting their HbA1c down as quick as possible. And this is, I think, the point of the authors made this point particularly, which I think was important, that young and middle-aged adults have substantially higher glycemic levels than older adults. So they're the ones that are probably more blasé about their management. So it's really important to improve their outcomes and minimize their complications. And these are the group we need to target because obviously their life expectancy is much longer. So in terms of, for us, what therapies do we have to manage their diabetes? So the Australian Diabetes Association's done a really good job lately of really giving us a fairly simple management algorithm, and it's a 2-page PDF. If you sort of Google that, Australian Diabetes Society type 2 diabetes algorithm, and it'll come up, and it's a very sort of compact algorithm and summary of how to manage diabetes. It has been around for many years now, but I think it's getting more and more, obviously the therapies are getting more and more complicated. So they've made quite a few updates in the recent years. So in the initial, and their algorithm is very similar to the American algorithm and the European algorithm. So it's basically across the world, across at least the Western world, there is a lot of agreement on how to manage diabetes. Some of the differences really just arise from funding issues, obviously. But, you know, obviously number one, as most people thought, is lifestyle and diet. So lifestyle and diet is really something that we need to emphasize to all our patients. And that is sort of step one. And it's something we need to revisit. And I think that's the importance that's come up recently in recent diabetes conferences across the world, is that although we do emphasize that initially to patients, but we need to revisit that approach to ask our patients, is there something we can improve in physical activity levels or in their diet? Not just, you know, immediately, but also 10 years down the track, 15 years down the track, 20 years down the track. So it's never too late to really make sort of non-treatment, non-pharmacological treatment changes to their lifestyle and diet. And then number two is determining their individual HbA1c target. So, I mean, commonly we say 7%, but if it's earlier on, I think the evidence is there to try to aim for as, you know, close to normal as possible, 6.5% or lower. Obviously, if they have lots of comorbidities, you might aim for a looser, looser controls for 7.5%. And if their life expectancy isn't very, you know, great, it's not a long way to go, and you want to give them, you know, comfort, and you do want to avoid hypos. So maybe heading towards 8%. And, you know, if you do change some therapy, that should be reviewed regularly. So every 3 months. So, you know, you could have a really great HbA1c, like in the first question, after initial treatment, but then is it still good in 3 months' time? And I know that GPs are really good at doing the management plans and making sure that the HbA1c is still to target. So just putting those steps in place. And then obviously weight is also a part of the management. So aiming for weight loss, which if the patient is able to achieve weight loss of greater than 10%, this might mean that they can cease a lot of their medications. And we do see this a lot with the bariatric patients where, you know, you're cutting out medications because they're losing weight. So to no surprise to anyone, metformin is the usual first line. But second line and third line treatments are a bit more contentious. And I think looking at the poll, a lot of people have moved away from using sulfonylureas, which is, I think, a really good idea. And there are lots of new agents now, and more are sort of popping up every few months to every few years now. So there is a lot to discuss in that aspect. So, and then the third line agent is probably just an add-on from the second line. Usually, you know, I tend to find that, you know, I'm starting something as a second line, but then the third line also comes fairly quickly if the HbA1c is not controlled, because a lot of the other agents after metformin aren't that effective, except for insulin, of course, unless they're achieving a lot of weight loss. So obviously you're trying to intensify their treatment as quickly as possible to make sure that you are meeting that HbA1c target. And then the fourth line is is a combination of other things. So there's other combinations such as sulfonylurea or adding insulin. And then if you're on basal insulin, you might consider adding SGLT2 or GLP-1 agonist or bolus insulin. So there's a few other more complicated options. And if they're very clinically complex, then consider referral onwards, obviously. Cost is often a factor, which I'll just go back, sorry. because there is quite a price discrepancy for all these drugs. So the sulfonylureas and metformin is very cheap, but when you're looking at the DPP-4s and SGLT2s and the GLP-1s and insulin, the costs are stacking up. So this is obviously another consideration for your patient. So the decision isn't easy. And I'm sorry to show you this busy slide, but I thought this is an excellent summary of all of the treatment risks, costs, whether they're oral or subcutaneous, what their renal side effects are, and what considerations are individually. And this is produced by the American Diabetes Association recently this year. So it's a sort of a nice backup chart if you do need it, if you needed some extra detail. So we'll jump into our options, which are there. And I just wanted to discuss, before we go on, some of the pathophysiology. So the ominous octet has been coined as a way of discussing all the pathways that are involved in diabetes management. So when I was going through med school, we were just talking about 3 kind of causes of hypoglycemia. Basically, the hepatic glucose output is high, and something like metformin targets that. You get your peripheral glucose uptake is reduced. So things like metformin help the muscles and the fat cells become more efficient in taking up the glucose. And obviously you have that reduced insulin secretion, which sulfonylureas and insulin are really good at improving the balance of. But now, more recently, there's been more pathways coined, such as obviously with the renal glucose excretion, and the targets are there with SGLT2 inhibitors. And then the CNS is often playing a role, which we don't really use in Australia, but a dopamine agonist can be used. And also, increasing the secretion through increasing glucagon secretion, which is also not a target in Australia, used in Australia. But these have been used in the past, and the glucose influx into the gut and so forth. And these are what is targeted by the GLP-1s, as well as the carbos. And I think if you're looking at sort of the reductions in HbA1c and the weight effects, this is an important consideration, because I find that when people are started on insulin initially, they do gain a significant amount of weight. And this is obviously in pounds and not in kilograms, but they do gain several kilograms in my experience. So it is something where you're chasing your tail a bit when people do start insulin, but obviously the reduction in HbA1c is so effective with insulin. And then inhaled insulin is not something we use, so I should have put a line through that, sorry. But sulfonylureas have a similar effect to insulin in terms of weight gain, but maybe a little bit less reduced. But they certainly have a significant amount of weight gain. But their HbA1c reduction is quite good if it's sort of the step before insulin. So, and obviously metformin is equally as effective, but it's at least weight neutral, if not weight losing. And things like GLP-1 is another target, because it does obviously cause that weight loss. But in terms of the newer medications, so the SGLT2 is not there, but it's similar in terms of DPP-4s in terms of efficacy, but there is a bit of a weight losing effect with SGLT2. So the newer drugs, although they are good medications, but they are probably not as efficacious as insulin and metformin. So just something to keep in mind, and sulfonylureas. So going on to the one of the newer classes of the SGLT2s. So in Australia, we have dapagliflozin, which is trade name Forxiga, empagliflozin, whose trade name is Jardiance, and ertugliflozin, which is the newer one, Steglatro. so they're not used for, or they're not approved for the use of management of type 1 diabetes, although sometimes they are off-label used in this setting. And I'll go into the mechanism. But currently we do have in Australia standalone or fixed combinations. The standalone is named as above, but the fixed combinations with metformin are called more interesting names. So Zigduo, Jardiamet, and Stegleromet. Sorry, I think I've spelled that wrong. Or with gliptins, Glixambi, Qtern, or Steglujan. So quite a mouthful. And basically the mechanism is in the macula densa of the renal tubules. So in a patient with diabetes, the tubules aren't functioning properly. And basically you get a lot of glucose being not reabsorbed by the SGLT2 inhibitor. So from the tubule into the basal membrane. And basically that means that there's less solute coming through the tubule. And when it reaches to the macula densa, that lack of solute is sensed and it causes the afferent vasodilation, as you can see here. And this is damaging for the kidneys because this causes the afferent vasodilatation causes increased hypertension, increased glomerular pressure. And then that eventually is thought to really contribute to kidney damage. So in SGLT2, what happens is the SGLT2 channel is inhibited. So the resorption isn't happening. So less molecules are being reabsorbed through here. So most of it's flowing through the tubule again, and then it feeds that back into the macula densa. And it doesn't sense that there is a reduction in solute. So there's no afferent vasodilatation. And that means that the glomerulus is working better. So that's why there's a lot of renal protective effects with SGLT2s. And the byproduct is because obviously the glucose is not reabsorbed, it then passes down and is excreted. The main disadvantage is obviously if the kidneys are impaired, that mechanism is not going to work. So if you have an eGFR of less than 45 for empagliflozin or for Seaguard, then that's not going to work. Canagliflozin is not available in Australia, but less than 60 for the other two. But there are trials sort of trying to push that eGFR lower coming up. But obviously, if your patient is on other diuretics, then that can be an issue. If they have very low carbohydrate intake, so there's not a lot of glucose passing through, then it may not be as effective. Although, arguably there's cardioprotective and renal protective effects, and bowel preparation, and perioperatively, which I'll discuss later. And the adverse effects are, unsurprisingly, dehydration, dizziness. Lots of, I find women have issues more than men with genital urinary infections, although men can have the very severe sort of Fournier's gangrene, which is rare, but is one of the sort of black box warnings on this medication. And obviously, I'm sure most of you have heard of the euglycemic ketoacidosis issue. So in terms of PBS guidelines, so this is always something to consider when you're using this it's not subsidized for use with insulin. So that's one thing to consider. And ertugliflozin is not as well subsidized as metformin and, sorry, it's only used for, in combination with metformin and sulfonylurea. Sorry, it is PBS subsidized for use with insulin, sorry. So triple therapy with DPP-4 is also PBS subsidized. So it can be used with DPP-4 and DAPA and empagliflozin can be used with insulin, sorry about that. But you can't use it as the first line therapy. So moving on to DPP-4s, which I've just mentioned. So alogliptin, Nicena, trade name Nicena, linagliptin, Tradjenta, saxagliptin, Onglyza, sitagliptin, Januvia, and vildagliptin, Galvus. So we've got quite a large range of DPP-4s in Australia. They're contraindicated in pancreatitis, hospitalisation due to heart failure with saxagliptin. And I think the only mild sort of side effect is often people can get a nasopharyngitis. So not often, but it can be one of the side effects, and it often is just a very mild sort of illness. But some people might find they also get a rash, obviously. I've never seen an episode of pancreatitis, but it is mentioned, and GI disturbance. So basically how this works is a different mechanism altogether to one we're used to. So basically DPP-4 and GLP-1s are what we call incretins, and they're glucose dependent. So when the patient eats, they have a rush of glucose into the gut, and that causes a release of GLP-1 and something called GIP, which is released in response to elevated glucose levels in the intestine, usually the small intestine, and the stomach as well. And these molecules are released to really cause increase in insulin release, but also a reduction in glucagon release. So what happens is that once they're in the system, the DPP-4, which is a molecule that degrades the incretin, so then they turn white and become inactive in this schematic picture, and then the incretin effect is blunted. So the DPP-4 inhibitor is then inhibiting DPP-4 molecule, so it inhibits the inhibitor and basically causes more endogenous incretin to be available in the system. So I find generally they have a modest HbA1c reduction, similar to what I reported earlier, 0.5 to 1%. They don't really cause a lot of side effects. They're really well used in the elderly, so I usually throw that in because they can be used, linagliptin particularly can be used regardless of renal function, so all the way up to even pre-dialysis and maybe dialysis stage. CKD. So it's just something that takes, maybe a 0.5 to 1% reduction in a patient's HbA1c. It can be combined well with metformin and SGLT2s, and it's PBS subsidized. It's weight neutral. So like I said, when you read the PBS criteria, it's quite complicated, but I find that linagliptin and sitagliptin are PBS subsidized with insulin and SGLT2s, but saxagliptin, vildagliptin are only subsidized for use with metformin and sulfonylureas. So, so linagliptin and sitagliptin are probably the ones I would use, just either as dual therapy or triple therapy, and they can also be used with insulin. In terms of GLP-1 receptor agonists, so this is the third, this is only used, available to be used as a third line agent. So we have now got quite a lot in Australia. So dulaglutide, which is Trulicity, exenatide, which has two forms, Byetta, which is the short acting, or the extended release called Bydureon. Liraglutide, which is Saxenda for weight loss, but Victoza for diabetes. Lixisenatide is no longer available. Semaglutide is the new one, new kid on the block, and that's called Ozempic. So these basically stimulate beta insulin release and slows gastric emptying. I'll go into that a bit more. But if your patient has a history of pancreatitis or pancreatic malignancy, then it would be contraindicated because it's been sort of traditionally thought to worsen that side effect. And some initial studies showed that it was query causing pancreatic cancer. But I think there's some debate in the community about whether that is true or not. However, it would be wise to avoid that in these sort of patients. you do need to adjust in moderate to severe renal failure and also stop it if they have pretty severe renal impairment. And there's quite a significant side effect profile. So they're not sort of mild in side effects. A lot of patients will report gastrointestinal upset, but then weight loss is also one of the good benefits. So this is just going into what the physiological actions of GLP-1 are in the body. So it is quite a ubiquitous molecule. It affects a lot of organs, so not just the sort of glucose-dependent incretin effect that I described. It also affects the beta cell, the size, the proliferation, the islet cells of the pancreas. It also sort of affects the guts, lipid metabolism. It affects the CNS control of blood flow, cardiovascular function, CNS stress response, immune system, and gastric emptying. So there's quite a lot of effects on many, there's a lot of GLP-1 receptors in our bodies. And this is showing what use of a GLP-1 agonist is known to do in the body. So if we start out with intestine, we know that it increases the growth and reduces lipoprotein secretion. There's a lot of probable good cardiovascular effects, so cardioprotection, increasing cardiac function, inflammation, and that's what a lot of the studies have really focused on, the cardiovascular benefits. And then there's a lot of effects on the pancreas, including increasing insulin, but also, as I mentioned before, the proliferation of beta cells, increasing somatostatin secretion and reducing glucagon secretion. There's a lot of CNS neural effects, not just around food intake, but possibly around neurogenesis and neuroprotection. There's some effects on the kidneys and also immune effects. So it's quite a interesting hormone. Interesting pharmacological pathway. And these are the ones that are available in Australia. So the exenatide is the first GLP-1 agonist, so I'm sure you're all familiar with them. There's 2 doses, 5 and 10 micrograms. Lixisenatide's been taken off the market, so it hasn't been around for a few years now. Liraglutide, this is the Victoza pen, so this is the one for use in diabetes, but it's not PBS subsidized, so the patient does have to pay for that. And there is also one called Saxenda, which I haven't got the picture here, but that's for weight loss. Exenatide by Durion, which is the once a week so exenatide formulation. And this is dulaglutide, which is Trulicity. So in Australia, I think we only have 1 dosage, but there's 2 dosages there. And this is a newer one, the semaglutide Ozempic, which has a few dosages as well. So I found a study which kind of compared, because I think one of the questions is which one is most effective. But I think in Australia, I guess the question is which one is PBS subsidized for a lot of the patients. And unfortunately, they're not all PBS subsidized, so it's a bit tricky working through it. If your patient is able to sort of pay for whichever GLP-1 agonist, then, I mean, looking at all these head-to-head trials, you might come out thinking that semaglutide is the most effective. However, it is sort of not a lot of, it's not been on the market for very long at the moment. So I haven't seen a lot of local data on it, but obviously liraglutide and exenatide and dulaglutide have been the ones we've all been using for the last few years. So in terms of PBS criteria, this is a little bit tricky. So exenatide Byetta, which is a short-acting, or exenatide ER, gelaglutide and semaglutide are PBS subsidized for use in combination with metformin or sulfonylurea or both. And it has to be a third-line option, so you can't really use it as a second line. And only Byetta is PBS subsidized for use with insulin. So this is a short-acting, so not the once-a-week formulation by Bydureon. So if your patient is sort of not tolerating Byetta and they're on insulin, then they're kind of stuck in terms of PBS subsidies. And so that's a tricky situation. Now moving on to insulin, I just wanted to quickly run through the newer insulins. But before I do that, has anyone got any questions?
Doesn't look like it, no.
Okay. Okay. Yeah, so just moving on to the insulin. So there's quite a few new insulins on the market. So we know sort of the regular insulin, the short-acting insulin, the short-acting insulin is the Lispro, Asparts, glulisine. You've got the regular insulin, which is Humulin R. You've got the NPH insulin like Protophane or Humulin N. Detamir, which is Levemir, is sort of not quite not very long-acting, but not sort of intermediate, so it's kind of in between. And then you've got the glargines, which is sort of tailing over towards 24 hours or more. And I thought this was an interesting sort of comparison. So looking at comparing the red line of insulin glargine, which we all used to know as Lantus, comparing the different profiles with NPH, which is also available as Protophane. So Protophane has quite a peak. Detamir, which is Levemir, has also got a bit more of an early peak than glargine. But with the new glargine, the U300, the Toujeo glargine, that looks a lot more flat than insulin glargine U100. And then Degludec, which is in Ryzodeg, and that's really flat and lasts, as we all know, closer to 42 hours in duration. So I borrowed some slides from my colleague Louise, and we did a similar talk, but pre-COVID, so face-to-face in the Central Coast Local Health District where I work. And so these were the new insulins back then, and they haven't changed too much now. So Fiasp is one of the newer insulins on the market, and there's one, and that's made by Novo Nordisk, and there's one coming from the competitor Lili. So that's coming up, the Humalog, sort of ultra rapid Humalog. So that's coming soon. Ryzodeg is probably, you've been all familiar with that, and we endocrinologists seem to love it because of that ultra long Degludec insulin. Toujeo is probably been on the market for a couple of years now, so no surprise to anyone. Opt-insulin has replaced Lantus. So if anyone hasn't heard of that by now, so this is the new Lantus. It's Lantus in that it's made by the same company, Sanofi, and they're calling it opt-insulin. So there's no more Lantus available. But there's also another insulin glargine. So this is not the only insulin glargine. So these two are both the same insulin glargine. So Semglee is made by another company. I'm not sure. I can't remember what it's called. But it's also insulin glargine. So they're biosimilars. So going back to Fiasp. So I guess the new thing about Fiasp, or the novel thing about Fiasp, is it's supposed to be ultra rapid acting insulin. So you're supposed to eat, you're supposed to have your food and take the insulin with your first bite of food, or if patients have sort of a slow meal, then they can take it a little bit after they've started eating, so up to 20 minutes post-meal. So yeah, however, the issue is you cannot use it with insulin pumps. So that's an issue because it's sort of not very compatible, although it's something that's very exciting for type 1 diabetes. But I guess with type 2 diabetes, I haven't really seen any of my patients ask for this. It hasn't been as much of an issue, but we'll see with the newer one from Lili whether there's any sort of improvement. And in terms of Ryzodeg, so just going over this for anyone who doesn't know, it's insulin degludec, which is that ultra long-acting insulin molecule, 70% of that, plus insulin aspart, which is the normal sort of Nova rapid insulin, so 30%. So it's in a similar proportion as Novamix, which we're all very familiar with. However, the long-acting insulin isn't insulin protophane anymore. It's insulin degludec, so it's that ultra long-acting. So it gives you a profile of this, and this sort of goes on, it tails off after 42 hours. So you can give it, it's recommended to be given either with the largest carbohydrate meal, or you can take it twice a day. I have seen some people do it 3 times a day, but it's probably not advised really. Lantus is no longer there, so I've said that, so it's been replaced by Optinsulin. And Semglee is so the competitor, so I've gone into that. So it's made by, I think, Biocon, which has actually been around in the market since October. So it has been around for a while now. And Toujeo is obviously your U300 insulin, and that is probably a bit more of a stable basal insulin, and it supposedly lasts up to 36 hours, and the profile is a bit flatter, so you're getting that basal reduction without sort of the peak in the first 12 hours that you do with insulin glargine U100. I'll just run very quickly, and you have these slides to go over if you need to. So SGLT2 inhibitors, the precaution with that is in patients who are perioperatively, so there's a risk of euglycemic DKA. So if your patients are undergoing bowel preparation, this is also something to think about. So I'll just move to this. So for surgical procedures, the guideline is really to cease SGLT2s at least 3 days pre-procedure, or 2 days prior to surgery and the day of procedure. So at least 2 to 3 days before your patient is having significant surgery. If they're having just a day stay procedure, so a gastroscopy or some sort of small excision or something, then the SGLT2 can be stopped just on the day of procedure. And insulin, I've just very briefly, so insulin, I think the optimal, I looked into this in terms of studies, and I think the optimal insulin dose before procedure, like on the night of before procedure, is probably about 70% of basal. So if we're talking about glargine, then 70% of the usual glargine prior to surgery. However, in terms of degludec, there's not a lot of evidence. So you can either switch to glargine just prior to the procedure, or you can give a reduced dose, 50 to 75% for 2 days prior to the procedure. And just on the horizon, there's I've talked about the tirzepatide, which is the Lyumjev, which is the ultra short-acting insulin. But then there's also a GIP and GLP-1 agonist, and also oral semaglutide, which is a GLP-1 agonist. And possibly, maybe in the future, there might be an oral insulin alternative. And I'll end there.